So good evening and welcome to our discussion tonight. I'm Dr. Albert Mensah. I'm co-founder of Mensah Medical and president and CEO. My partner, Dr. Judith Bowman, who works with me, is not here, of course, tonight, but she's always here in the spirit of an activity. One of the things that's very unique about our clinic is that we actually work with patients together. So you typically have two Dr. Brains working on your behalf as opposed to just one. But now let's talk really about Alzheimer's as a disorder. And some have called it a disease. Historically, we look at Alzheimer's disease as really being discovered in the 1800s. And many people may be surprised that we've actually known about it that long. One of the difficulties is that for almost 100 years or so, there hasn't been a lot that we've been able to do about it, really until now. We've been trying pretty hard, but our successes haven't been terribly great. Historically, we know the name Alzheimer's because of Dr. Alois, excuse me, he's French, so forgive me. No, he's not, he's German. Alois Alzheimer's. And this individual is a brilliant psychiatrist. And he noted that with many patients who had dementia of some type or another, or strange mental processing, there seemed to be the question as to whether or not there was something structural as a problem, some dysregulation in the brain. So he did a lot of autopsies, and he was actually one of the best at describing many of the pathologies that were seen in the brain of the human individuals that he basically worked on. And so basically he was given credit for the name Alzheimer's as the name of the disorder. Now, he also happened to work in the laboratory of his esteemed friend, Dr. Emil Kraepelin. Dr. Kraepelin was the noted psychiatrist who wrote the Handbook of Psychiatry back in those days. And Dr. Kraepelin was also the man who was well known for coming up with the diagnosis of manic depression. So he's extremely well known. And in his Handbook of Psychiatry, he actually wrote dementia, and he used the term Alzheimer's dementia in honor of his friend who worked in his lab. Now, there are many people who actually believe that other researchers really deserve the name more so than Dr. Alzheimer's, but that's the name we have today. He presented this stuff back in 1910, and that beautiful description just kind of has flowed throughout. And what does that description involve? He talked about neurofibrillary tangles and amyloid plaques, and anybody who's done a research or read about Alzheimer's knows that these things are commonly seen in the human brain. So Dr. Alzheimer's described this very, very well. Now then, that's all fine and dandy, but what's the real deal with Alzheimer's? What is Alzheimer's? Is it a structural phenomenon? Is it functional? Is it a combination of the two? Many of us are really still trying to figure that out. But what we do understand is the end result, which is initially beginning with a mild cognitive decline and then moving on from there. So we talk about Alzheimer's as a progressive and degenerating cognitive disorder. And I think that's the best way for us right now to really describe this phenomenon. Because those of us who are busy studying the structural abnormalities can't come up with anything consistently to say except that they're there. How they disrepair the brain seems to be of question. We kind of assume that they cause problems because they are there and seen in most patients with the disorder. But when we try to remove or fix those issues, remove those plaques, or prevent them from happening, that doesn't change the progression of the disease. So the question becomes, what is the real significance of those particular structural abnormalities? That's why the definitions that we tend to use are more about function than they are about structural brain abnormalities. Let's talk a little bit about some of the warning signs. And of course, everyone would probably say, well, quite naturally, it's a memory issue, right? It's a situation where first you kind of notice loss of interest in activities of daily living. Things that used to be fun for you is really what I'm trying to say. You know, you don't want to go with the girls anymore and meet on Thursdays or Fridays. You may not want to go to your usual walk or the park or things you used to be interested in doing. Now, at that point in time, maybe there isn't significant cognitive impairment. And everyone's thinking, oh my gosh, I'm there now because it's cold in Chicago and we don't want to do any of these things. But no, that's not so much the case. It's a lot more involved in that. When you start talking about the early signs, however, of Alzheimer's disease, now we're talking about the things that most people are really familiar with. We're talking about early memory changes, and those memory changes are for recent memories, while long-term or older memories pretty much remain intact. Things like, oh gosh, what did I do yesterday, and where did I leave that thing? And now everybody who's 20 years and older believes they've got Alzheimer's just by that description. So it's not quite as cut and dry as that, but those are signs of the early stages of Alzheimer's. When we start talking about more the moderate stages of Alzheimer's disease, now we're really looking at some things that are truly, truly impactful. People stop recognizing individuals. They may not remember their own grandchildren. They tend to forget or lose interest in what we call true activities of daily living. Brushing your teeth, putting on your clothes, shoes that you wear, where you go. You can forget driving. Okay. A lot of these basic things are seemingly lost. We had a patient earlier this week, and what we saw in this individual was exactly that. Beautiful at sort of disguising the phenomenon. And that's what happens also in the very early stages. Individuals tend to kind of hide the fact that they're having cognitive decline and memory challenges. So when they meet you and say, well, would you pass me that? And you say, pass me what? Say, well, the writing implement. Okay. Or, that thing that I used to drink out of, would you just pass me that over there? And it seems cute and it seems funny at the time. But what they're really saying is, I can't remember the name of that item. Okay. And that's a sense where we have something we have to kind of pause about. One of the early things that we notice about Alzheimer's or the decline at the beginning of the process involves smell. Olfactory senses tend to be one of the first things to go in Alzheimer's. Now, we actually had a set of tests that we did back in our old institution where we had a set of 22 smells or odors, and they were on these little strips of paper. And we gave them to almost all of our staff just as a tester. And I won't name any names, but one of them works here. She became extremely offended at the fact that she missed one of those smells. She was sure it was chocolate and it turned out to be almonds. And I said, is there a little cognitive decline going on there? And of course we had a good laugh about that. But the idea here was that individuals who seem to have these challenges with regard to smell recognition or odor sensitivity may be displaying some of the very early signs of that process. Now, we know with statistics, there's always something that sort of says, no, that's not 100%. Well, one of our younger individuals, younger being he was in his 50s, he couldn't get 50% of those smells right. And he got very upset, and I said, you know what, Mr. So-and-so, don't even worry about it, because this is not a 100% guaranteed test here. It's an example that we're looking at broadly to really determine how significant smell is as a variable. But nonetheless, in older individuals, smell declines for a variety of reasons. So it's not 100%, but it is one of the variables that we do look at very, very, very early. Now back to the moderate side of things. These poor individuals, by the way, who are in moderate stages of Alzheimer's disease, can still somewhat function with the help of family members. There may be some prodding as to, well, here are your clothes, and I'm laying them out for you. You put them on. Maybe this is how you put on your shoe. Or, honey, would you please brush your teeth this morning? Sometimes it's what's called an agnosia. They do not recognize people or things, so that kind of processing is somewhat lost, but they're still able to functionally do things mechanically if you prime them. Okay. Horrifically, in the latter stages of this disorder, individuals lose that capacity. They may have what's considered to be sort of a wooden face or wooden facade. There's no expressions of joy, of life. Writing and reading skills may start to decline in the moderate stages. They're certainly gone by the severe stages. Individuals may not be able to do much of anything, and ultimately they perish, usually within that time frame and that reference range. It's not one of the more pleasant aspects of life, but in describing sort of the stages as we progress from early warning signs to severe dementia and severe Alzheimer's, that's typically how it tends to progress. By that point in time, though, individuals are usually in some institution at that point because they're far beyond the capacity for usually most family members to sort of be able to handle the kind of care that's required for these individuals. So it's a very disconcerting disorder. It affects about 4.5 million Americans today. And that's a huge number. Or is it? Because what we're seeing is two things. Number one, the baby boomers aren't quite yet older. They're getting there, but they're not there. When that population hits, what's going to happen to the relative numbers that we've been talking about thus far? The idea here is that, well, let me give you this little statistic. Roughly about a third of Americans will develop some type of cognitive decline or Alzheimer's or Alzheimer's-like disorder. So now we've got, currently 300 million Americans present. And let's just say those X number of millions are in that particular age category, over 70. But we know a third of them are going to develop Alzheimer's or these conditions at some point in time or another. So whatever demographic, whether it's small or large, at the time where the 70s are approaching, we're going to see an expansion of those numbers, which is why it becomes extremely significant. Something that's newer, I remember when I was first giving these presentations on Alzheimer's, we were talking particularly about individuals who are older. But we've got two new demographics that are extremely concerning to me and to a lot of people. Number one, I'm just going to call a spade a spade. I'm going to talk about fat kids. Okay? To be very blunt, we're going to talk about really obesity. That's become a big issue in our culture. And that's affecting not just older folks, of course. We're talking about kids, our children. Because of video games, because of inactivity, for whatever reason it may be, they are now more so at risk. And you're saying, wait a minute, Dr. Mensah, I've done lots of reading about Alzheimer's and I don't remember anything about children who are on the corpulent side. Well, let's add to the corpulent side individuals who have insulin resistance. So not even diabetes, which we'll get to later, but insulin resistance. These are the kids, or the people who tend to have larger midsections and they're not quite responding. They have elevated sugar levels. What does that have to do with Alzheimer's? Well, these individuals, because of the glucose dysregulation and the inflammation that develops as a result of this, are also at risk for later on developing Alzheimer's disease. So now let's look at where we are. We've got baby boomers on the one hand, moving up in years. We've got the younger kids who are going to be moving up in years. We've got a staggering rise of obesity in the American population. What is that going to do to the demographic of people who are diagnosed as having Alzheimer's? Now, there's such a thing as the prevalence, and there's such a thing as the incidence of any given disease or disorder. The prevalence is how much of this is really going on in society now. Incidence is how many actually develop the disorder. I want to talk about the prevalence in the future, because if we don't do some things about factors that we can change, like obesity, and therefore diabetes and insulin resistance, we're going to have a double demographic swarming and invading our medical institutions. It's going to be the individuals with physiological disorders, and then the older individuals, a third of whom would statistically develop these conditions. So now we may start to move into a much broader realm of what we might even consider to be an epidemic arrival of things like Alzheimer's and those kind of disorders. Okay. Let's talk about other risk factors, because I think I just already started on that path. We talked about age. We said roughly about a third of individuals who are over 70 are going to develop Alzheimer's. One of the things I want to bring up that's been in the news lately is head trauma. Head trauma of any frequent nature type, or even just severe head trauma involving loss of consciousness or otherwise, can actually predispose to Alzheimer's disease or Alzheimer's-like conditions. I want to talk about conditions that are like Alzheimer's in that they may not have the neurofibrillary tangles or the amyloid plaques, and we really won't know until much later on after autopsy, but they start to reveal themselves or manifest in ways that are similar to what you would see with Alzheimer's. Memory deficits, all the other issues that come along later on seem to be flowing through these individuals as well. Now, who is that we're really sort of talking about here? We've known for a long time that boxers tend to seem kind of strange and funny later on in life. I'm not going to name any names, but you know of some world-class boxers who've had cognitive issues. There's even an entire foundation that has been established for Jerry Quarry, famous boxer who fought for a world championship, and his family has established the foundation for individuals with Alzheimer's, especially those who suffered head injuries. So not just boxers, are football players. What's been big in the news lately? The NFL. And by the way, the NFL is sponsoring many institutions doing research in the development of dementia to try to stop it from happening or to help those individuals who suffered with it, who used to be former athletes. These individuals who were just bright and great stars on the field, after repeated incidents of head trauma, now have cognitive decline. And I'm going to use that term because I've not diagnosed them or know their specific diagnosis of dementia, but their memory is shot, their functionality is shot, their capacities to properly work and move through life are severely hindered. And so we have to look at these things very seriously. Now, a lot of people are not going to like what I'm going to say next, but what is of great concern to me now are children. Once again, back to the kids. Now, these are the active ones that we're talking about. But these are the active ones who are doing things like playing football. We don't know enough about this disorder yet to say 100%, that's even 90%, that children starting with pee-wee football or any form of contact sport that involves severe head injury or repeated head trauma is not going to have an effect on their later capacities or later tendencies to possibly develop Alzheimer's or Alzheimer's-like conditions. So with Dr. Mensah, we're talking about kids who are 8 or 9 years old. They're tough little fellows, and they're all sorts of things. They're just stable, and you drop them from the ceiling, and they're just going to bounce off the ground. I've often said that, but the fact is, what happens when we have a brain injury or trauma? If you've ever been in a motor vehicle accident, you know that there's such a thing called a counter-coup injury. You think that when the head slams against something, it's the front part that made the contact where a lot of the damage would be. But in counter-coup injuries, remember, the brain sits in a fluid, and it's sort of tethered to the skull itself. Okay? So when you have an injury that involves sort of a whiplash effect, the forehead of the brain may hit, but then the brain goes forward and then back. So there's a shearing effect sometimes with nerves. They may be small, but every single little trauma may have an effect in the long run. We don't have studies on that yet, but logic and physiology says that this is something that should be of concern to us. So when I get a parent who asks me about their child and whether that child should participate in certain sports, I have to ask some very important questions, like, well, how strongly are you really interested in your child doing this? And let's look at the ramifications of them being in this particular sport or this category. Because we know you want your kids to be great athletes and football stars. We know you want them all to go to Harvard and Yale and Princeton. We know that you want them to be geniuses and become corporate CEOs and maybe be president one day. But that requires brain functionality. Now, probably going to get a lot of phone calls from coaches and a whole lot of other people. But we have to talk about certain realities of things that can contribute, because this is not the same world we lived in 20 years ago for a variety of reasons. Our diet is different, our activity levels are different, we're learning more. And the question is, I think we're putting ourselves more at risk than we did in the past. Other very important variables when it comes to risk factors for Alzheimer's disease. We talked about age, we talked about athletics, we talked about dietary issues. We'll actually get more into dietary issues. But one of the most important things that people worry about is family. Okay. Well, Dr. Mensah, I've got a relative, a parent had Alzheimer's disease. Am I doomed to have Alzheimer's disease? The answer is no, you're not doomed to have Alzheimer's disease. Might you have an increased risk? There is that possibility. Now, what does that really involve? Well, number one, there's conjecture. Simply saying, we're related, the odds are I've got an increased risk. Number two, there is scientific testing that's involved. We can look at one variable called the apoproteins, ApoE proteins. And we've noted in science that ApoE2, 3, and 4 are all variables that we get from our parents. And if we get double doses of these things, that could put us at increased risk. Now, ApoE2 has the lowest risk for Alzheimer's disease development. E3 has a moderate, and E4 has a very severe or much higher risk of having Alzheimer's disease. But the problem with genetic testing is that there's always sort of these caveats around that. For example, even though these APO genes may be present, and when you test for them, they show you there's a significance or a certain risk factor for them, the other side of the story is that 40% of individuals who develop Alzheimer's don't have any ApoE proteins that are showing up as risk factors. And yet, they simply are not going to develop it. Okay? So, we cannot say for sure that just because you have an ApoE protein dysfunction showing up here, or that you don't have it, by the way, doesn't say one way or the other that you're 100% or 80% going to have Alzheimer's or not going to have it. Okay? So we look at these things really for what it is they're worth. They're indicating a risk. When they are present, the ApoE4 protein is suggesting that there's somewhere between a 10 and 30% or 10 and 30 times increased risk for the individual who has Alzheimer's as opposed to the individual who does not have those particular proteins. Okay. But there's a lot more than just a protein involved to determine your risk likelihood of developing Alzheimer's. Certainly there's issues involving diet, exercise, activity, education. Another interesting discussion. Well, we often say that, keep the mind active and you reduce the likelihood of getting Alzheimer's. And there's truth to that. An active mind, educational levels, they've all been associated with a lower risk of developing Alzheimer's around age 70. Okay? But here's the interesting thing. For all the lovely brainiacs out there who've gone to do graduate school and all sorts of fun things, very sharp-minded individuals doing well. But later on in life, if they develop Alzheimer's, their decline is much greater. Much more severe decline and rapid decline for these individuals. Well, I'm not saying don't go to school. I'm just saying that let's not presume a 100% protection from any risk factor because you fall into one category or another category. Now, on the other side, staying mentally fit is always going to be a good protective variable. There's just no 100% guarantee for it. Okay. Now, by the way, that doesn't mean that individuals who didn't go to college or who have a lower mental processing capacity are necessarily going to be much more severely at risk. But there is a correlation that would say that lower educational levels do correlate with a greater tendency for Alzheimer's. Okay. So now we've talked about education. We've talked a little bit about activity levels. Now let's talk about physical activity for a minute because we kind of talked about that earlier. There are safe sports, of course. Not everyone has to be a rough and tumble, head-banging individual. But physical activity in general does a lot of things in the system. It produces certainly a release of lovely chemicals that fight disease. It produces hormones that have a very positive effect in the system. And so I'm not going to say that diet and diet modification is the key to preventing Alzheimer's. It's the key to helping a lot of other disorders not cause Alzheimer's. So it's beneficial in general, but we're not going to say that it's one of the major elements involved here. Okay? Now, let's talk about some of the treatment paradigms. And in order to do that, I want to move a little bit into some of the basic theories that have been out there about different causes of Alzheimer's biochemically or molecularly. When we were first looking at, just say drugs and drugs that have been developed, one theory that was out there was that there was this concept that acetylcholine was actually diminished early in the stages of Alzheimer's development. And our scientists said, Eureka! We have found the key to taking care of Alzheimer's. It's acetylcholine. So we're going to get busy. We're going to develop drugs like, well, I won't say the names, but drugs that help increase acetylcholine activity in the brain. And when we use these drugs, guess what? We're going to stop Alzheimer's. What happened with these drugs? Well, some very interesting things. Cognitive functioning improved for a good 4 to 12 months. And we sat back in all of our great almighty wisdom and knowledge and said, we have done a fabulous thing. Until we realized in all of our humility that patients continued to decline and they died. So they died with a smile for a good 4 to 12 months. These drugs were not the key because it was not acetylcholine that was really the problem. As a matter of fact, what we found out was that acetylcholine levels were not low at the beginning of the disorder. They were low later on in the disorder. So the acetylcholine hypothesis really had to be kind of put away somewhere. Other drugs that we developed stimulated glutamate receptors or glutamate activity in the brain. Another very positive finding occurred similar to those drugs that used acetylcholine, and we've all heard of them. You know, these are the Mendas out of the world, you know, the Ariceps with the acetylcholine supporters. And we're not saying there's something wrong with those drugs. What we want to say is that we have to keep things in perspective. Treatments, cures, or supportive systems. Because right now we didn't have anything that was really sort of a key cure. We do as much as we can to support the functioning of the brain while the individual is still here with us. And that's what these drugs tend to do. They help us function better, but unfortunately they don't stop the decline of the disorder. Now, there's a very interesting scenario that occurred when older individuals who seem to have cognitive issues, memory challenges, got sick one day and got fevers. And so their family members gave them anti-inflammatory agents like ibuprofen. And something really interesting happened. People started reporting that, you know, when Great Aunt Sue was on that ibuprofen, I was pretty sure she remembered who I was. I was pretty sure she became more interested in activity and different things for a good 3 days until we stopped, and then she went right back to normal. So then the idea of inflammation and its role in cognitive decline came into being. So we started paying attention to that and said, wow, gosh, so if we perhaps can stop inflammation, then maybe we're going to see significant progress with our patients, and maybe there'll be this whole great trend of improvement, and that may be the key to the answer to many issues. Well, I can tell you now that the person who develops the key to stopping inflammation, negative inflammation of the human body, is going to become a multi-trillionaire, because most disease processes, most organ system processes that go wrong, travel through the pathway of inflammation. So that was a key, but we're not too sure about that one functionally yet. Well, there came another particular process that we were concerned about, one called oxidative stress. Now, oxidative stress involves free radical elements in the system. Yes, not that group from the 60s, the free radicals. We're talking about a different group. Okay. These are internal molecules that actually are used to kill bacteria, to kill disease, to kind of solve great problems within the construct of the human body. They're actually very, very good. However, when there's too much free radical activity, that can involve cellular death and brain decline, and it can lead to inflammation. All these things we're talking about here are relative to what we're calling oxidative stress. And it's that oxidative stress that we're looking at very keenly as being a key element in the development or the process by which Alzheimer's disease works or moves through. So what we've done at Mensah Medical and at institutions similar to ours, actually pretty much us and those we've trained abroad, we're looking at this phenomenon of oxidative stress. And what did we find? Well, preliminarily in our studies, we found that roughly about 75% of individuals who were treated with these antioxidant stress regimens actually did pretty well. We began with a curiosity. The curiosity was, we've got some therapies that help oxidative stress. We know that they work in certain conditions like autism, but would they work in conditions like Alzheimer's? And you're thinking, wait a minute, Dr. Mensah, Alzheimer's and autism, these are two very, very different conditions. Yes, they are, but at the same time, what's the commonality? The commonality is that both involve severe oxidative stress. So we went ahead and tried this, 100 patients in our initial study. What did we find? Our curiosity was, could we stop the progression of the condition? That's all we wanted to know. Well, in a good 75% of those individuals, statistically, the progression of that disorder stopped. So how do you know that? Was that just something that was reported to you? So, well, no. We did a few tests beforehand. Some of our criteria, of course, involved doing a typical mini mental status examination before a patient was even initiated in that therapy. But then we also used the Cambridge Neuropsychiatric Aptitude Battery, called the CANTAB test for short. It's a computerized test that patients have to sit through for 1 hour and 10 minutes, basically moving through the process of manipulating diagrams, answering questions, and so forth, as our standard. We started that process, and then we retested every 6 months or so. And that was one of the major guidelines that we used to determine cognitive functioning, in addition to what it is the family members told us. And we had some very, very surprising news. Somewhere between 40 and 50% of the patients not only did not decline, they actually regained memories. It just blew us away, because we weren't looking for that. We were shocked, as a matter of fact. We said, could this be right? So we continued to look more and more at this phenomenon. What we found was that there are individuals who are remembering their grandkids. There are individuals who remembered memories 6 months prior to what it is that they had lost. They couldn't remember all these things, and it came back. Now, are we talking about some miracle cure? Absolutely not. What we're talking about is a very, very strong and promising therapy that we've been utilizing. But the fact is, because we do not have the double-blind studies that are typically required, we cannot say that we have a cure. What we can say is that we know of a therapy that tends to be pretty good thus far in a good 70 to 75% of the patient population. Now, what is that therapy doing? It's working against oxidative stress. And here's the key. In our brains, we have a lovely protective barrier, the blood-brain barrier, we call it. And that barrier is responsible for basically dealing with preventing inflammation, stopping toxins from getting into the brain as much as possible, dealing with inflammation, toxins, regulation of glucose, certainly, and a variety of other elements that come into play that could be problematic for the brain. Many individuals with Alzheimer's have a weakened blood-brain barrier. And so healing that blood-brain barrier becomes very, very important. We didn't talk about metals too much, so I want to give a brief shout out, as the kids say, to metals. Certain metals can be very, very toxic or problematic to the human brain. We've heard a lot of things about mercury, not just in the autism community, but also in the Alzheimer's community. Building up of toxins like mercury, cadmium, represent big problems in the human system. What we found out was that copper, which can be very big in postpartum depression, in females with menstrual irregularities, and a variety of other areas, we found that copper in high levels can be very problematic because it also acts like a free radical. It causes a lot of problems with cellular activity and with cellular structure. So we knew too much copper was a big deal. But then we also found out that too little copper could also be problematic in the brains of Alzheimer's individuals. So what we say now is that copper regulation is very key in maintaining what we call homeostatic health, that is, the proper balance of health in the system of individuals with Alzheimer's. Now, there's so much research going on in this field, and we don't all know everything. It'd be great if we could all get together in a nice room and talk about it all together, because there can be many serious problems that arise. We often will publish data that's based upon sometimes just coincidental situations as opposed to actual correlational or causal phenomena. I was reading one article one day, and it said that zinc may be the key to Alzheimer's, because they noticed that in Alzheimer's individuals, they had high levels of zinc present in them. And I just sat back and I said, oh my goodness, there's a big problem there, because what the article is telling people is that high zinc concentrations in the brain may be bad for you. Well, if you happen to know about certain proteins in the brain that are supposed to actually regulate the function of metals, those proteins in the brain use zinc as fuel. So what they do is they grab onto the zinc that's there, run it through their machinery so they ramp up to do their job of metal dysregulation or metal regulation and a variety of other things. But then when they're done, they spit out the zinc. So that zinc gets deposited in the brain, and it's not that there's too much zinc that's the problem. It's actually showing that the machinery, the brain's own machinery for regulating metals and toxins, is working well. And that is actually putting the zinc that's out there into the system. But once again, we're not all talking to each other, so we don't recognize these things. And many people who are watching this one day are probably going to say, yeah, Dr. Mensah said that, but you know what? He doesn't know this and doesn't know that. And it's true, I probably don't. But this I do know. Okay? And that's from our researchers at the Walsh Research Institute. So when we're talking about these conditions, there are tons of variables. The good news is that there's a lot of work being done in this area, and we have a tremendous number of people who are working to try to change what's going on in the system. Now, I want to give an honorable, or in some cases a dishonorable, shout out to the idea of the amyloid plaques, the neurofibrillary tangles, and the tau proteins that are out there, molecularly speaking. We have spent tons of money and tons of research looking at these plaques, these proteinaceous entities that look like little stuck-on red pieces under the microscope, okay, and little blotches. And we presume because they're there, they have a functional role in the destruction of the brain that leads to the cognitive processing challenges of Alzheimer's disease. And also these neurofibrillary tangles, these lovely coiled up structures that are no longer nice, clean, long neurons, they're curled for some reason. And we said, well, that's probably one of the issues too. So we've got these two camps in most of Alzheimer's research. We've got the neurofibrillary tangle people, and we've got the amyloid plaque people. And you know what? Most of them don't like each other because they're the other team. They're looking in the wrong place because we know what we're doing. We spent 50 years looking over here in the light, because there's only one lamp, and we're not looking anywhere else. And these guys say the same thing. And these folks over here, and the fact is, statistically speaking, we've not seen any real promise, proven real promise over time, with regard to the idea of the amyloid plaques or the neurofibrillary tangles. Now that's me saying that, okay? You guys can disagree with me all you want, but we've seen far too many studies. If these ideas were true, by the way, then if we can prevent them from being produced in the first place, we should see some resolution of the disorder or not see the disorder at all. Now, there have been drugs that have been created in many studies that could actually remove these plaques. Guess what happened when you removed the plaque? There was no change in the progression of the disorder. And when you dealt with the tangles, once again, no change. And tau proteins, the same thing. Now, having said all that and gotten a whole lot of people angry, I'm sure, let's talk about the other side. There are some promising drug therapies that are newly in development that make the assertion that as removers of these plaques, they've actually had individuals regain memory. Okay. We're waiting to see how this sort of really pans out, to be fair, okay, over time. But one of the things we can say is, yes, indeed, they just might gain memory back. And it'll probably happen for about maybe 6 to 12 months, but the condition is most likely to decline. Okay. I didn't mention any names, so no one's going to go out there and sue me. I'm just saying it's a concept. Okay, let's be careful about that. Our therapies are not drug-based, and that's the major thing we want to put out there. Okay, we're not talking about the use of some construct that is going to be in any way detrimental. And many of these drugs may not be detrimental at all. That part is not the issue. The issue involves, are we looking in the right places with regard to how to approach this disorder? We're still not sure. Now, the people who say they've got great results, I'm sure they're very sure about that. And believe me, if these particular therapies work, you're going to be looking at one of the happiest people around. Because none of us, we don't care who's right or who's wrong, as long as we eventually come together to get the right answer to help individuals, that's the key. But in our discussion, we also have to talk about some of the myths that are out there and things that have been tried for a long time that simply haven't worked. And that's why I presented things the way I did with regard to these proteins, with regard to a lot of different preconceptions and areas and thoughts we never even had before, such as our children and obesity, possibly being at risk for Alzheimer's. Who's thinking about an Alzheimer's in an 8-year-old or a 9-year-old, or heaven forbid, a 10-year-old? We think about it from the perspective of course, individuals who've been football players that are adults, boxers, individuals who had head trauma, car accidents. But, we have to look at the entire picture. Disease states like diabetes, like hypertension. We've also seen that a lot of these disorders, like strokes, cardiovascular accidents that affect brain flows of oxygen, all have an impact on the brain itself and how the brain can function because it causes cellular death. How do we function in the brain? Well, we've got to have nerves firing and nerves talking to each other. Now, every single nerve in the human brain has a support team. We call them glial cells. There are about 3 or 4 glial cells whose sole job it is to help support this one major cell, make sure it gets the nutrients it needs, and then it can do its job of firing electrical components so that it can communicate with the next cell. Okay. When we don't have blood and oxygen moving into these cells, they die. And when these cells die, they can't support the major cells. The major cells die, we have no communication. So disorders or disease states, whether it be hypertension, whether it be stroke, whether it be atrial fibrillation and heart attacks and issues, anything that compromises blood flow to the brain can be a major risk factor for the development of Alzheimer's disease. So it's not simply about your heart, it's not simply about your stomach, it's not simply about your thighs. We are one body. What affects one part is likely to affect another part. And you'd be amazed. One of our favorite athletes, basketball player recently, I'm not going to mention names, but he had another injury. Now he's out, okay? And one of my colleagues and I were talking about this. We said, doggone it, by golly, we just got him back. Fixed up that one body part, and then there's another injury. And my first thought when I heard on the news was, did this happen in the same leg, or was it the other leg? And why did I think that? Because while this leg is injured, what do? We try to compensate the other one. So we produce more stress and more tension on the other leg while trying to save this one. But guess what the rest of the body does? When we've got compromised vasculature, when we've got areas that are challenged, other systems try to compensate. And when they do, we're putting more stress on them. Okay? So the idea here is, we sit down and we talk about diet. Well, how does diet relate to stroke? How does diet relate to hypertension? How does diet relate to the development of Alzheimer's disease? Well, the American diet almost speaks for itself. We've heard lots of bad press about it. What typical Americans do, not what the theorized good stuff is. But you think that's just making your stomach big and thin, or hips in either sex. It's not that simple anymore. It can be paving the way for major disease or destructive developments in brain and cognitive processing later on in life. Okay? Now, I promised I wasn't going to be quite so verbose today. I guess I could help myself. But now I want to open the floor to questions, please. Oh, yes. Talk about myths. I hate to burst any bubbles out there. Okay? There was this huge... Did everyone not hear about the whole coconut oil thing? You did not hear about it? Wow. It was all over the place. Even I heard about it. coconut oil was being touted as something that could really potentially help in Alzheimer's disease and cognitive dysfunction because, quite honestly, it was the new kid on the block. Oil, coconut water, people are just selling off the shelves. And I kind of sat back and I said, now, let's look at this really. And we started doing more research into this phenomenon, and really it was determined that coconut oil has no definitive proof that is of any benefit in Alzheimer's disease. There may be some coincidental constructs present, but no more significant than many other foods or items out there or oils out there. Good stuff. And, I was actually talking to one of our folks earlier today, and I said, well, we can talk about theories and people can believe whatever they want to believe, but I'll share with you this story. I'm not a Native American, born in America. I was born in another country. And in that country, which is on the African coast, Ghana, West Africa, there's a whole lot of coconut floating around the place, okay? We have lovely ladies who come in the morning, and I can just smell it now. They carry fresh coconuts on their in these pans on their heads, and they'll stop at your house, ask if you want some. Believe me, they make money. Okay, and they'll cut up the coconuts for you, and I can taste it now. And you get to eat them, and so there's a lot of coconut utility and coconut oil in Ghana. There's also a lot of dementia in Ghana. Okay, now. One factor could say, well, sure, maybe everyone's just obese, maybe they just stopped doing this, and a lot of other things going on. It doesn't mean that it's bad for you or that it's good for you. Well, the fact is we simply don't know. So I'm saying don't go out and rush to collect coconut water or coconut oil or whatever have you and think that if you're cooking in that stuff, you're safe and you're protecting yourself against Alzheimer's. No, it's not that simple. Okay. While we're on that, let's talk about wine. Who knows a glass of wine is good for you? Who knows 2 glasses of wine may be good for you? Who knows 3 glasses of wine may be good for you? Don't believe it. Okay? We see people out there, hey, I'm just doing my duty to keep my cardiovascular system healthy. Give me that entire jug over there. Well, no, we know that 1 glass of red wine may be beneficial for cardiovascular issues, but also may be very protective against issues involving dementia in the brain. Now, 2 glasses a day, just kind of keep it right there, not going beyond that, okay? Too many glasses of red wine, by the way, can actually cause the reverse issue to occur, okay? Degeneration and insults and oxidative stress. So let's not use wine as an excuse, because the same elements that are present in wine are also present in grapes. Why don't you just eat some grapes and leave the alcohol alone? Well, it's kind of hard to sit there and look cool with my glass of grapes over dinner. Okay. Any other questions?
You mentioned that you did a study on Alzheimer's with 100 different patients.
Correct.
Can you just talk maybe a little bit more about that? What did you said maybe 75% experienced a halting of the disease?
Correct.
What about the 25%? Did they get the 25 that
yes. Very important things. Let me say that we learned some very interesting things. Sometimes I'll read studies and I think people, I'll be honest, I think people are stupid. I said, let me get this straight. You spent $1.2 million on this study to come out with this end result that every single person on this planet knows. It seemed very commonsensical to me until this particular study that we did. And then I had to say, it's not always quite so commonsensical. The failures, or the people who didn't do so well. You know what we discovered? You cannot give a treatment therapy to somebody who lives alone.
Okay.
Duh, right? It wasn't the case for us. We didn't screen individuals for did they live alone or were they with their family members. If they lived alone, they either forgot to take their nutrient program, today, tomorrow, a few days, or they took too many. And when they took too many, that wasn't going to happen either, because anything can become problematic and toxic over time. The water you're drinking right now, ask any doctor to tell you, you can kill yourself with water, okay? Drinking way too much of it. So what we learned was that X number of people were living by themselves, and they were not taking the treatment protocol appropriately. that was one of the reasons why we didn't have success there in that side. Now, there are about 5 to 10% of people who are simply recalcitrant for some reason. They were non-responders. The third thing we learned from that study was that you had to be in the category of mild to moderate Alzheimer's. We could not do anything, and to this day we still cannot do anything from a statistical perspective regarding moderate to severe Alzheimer's. Okay? So our screening is very, very key. We look at individuals who are only in those early stages, and that's when we can tell them, listen, you've got a great statistical chance here of improving. When we're in our moderate to severe range, we kind of go, wow, listen, we can try this, but I can't make you any statistical guarantees. I can't make you any statistical promises. I can only say that maybe it'll help, maybe it won't. It won't hurt under our guidance, okay? But I can't tell you that it's going to be a key gainer for you if you've already moved beyond a certain point. So those are some of the things that we learned from the study. That number one, you've got to have a person who is, because compliance is always key, you've got to have a person who's being monitored by somebody, a family member living at home or something along those lines. Number two, we could not do anything about moderate to severe Alzheimer's. Okay, they're too far gone. If we are mild to moderate somewhere in those stages, we've got a good chance. Okay, and then number three, like anything else, not everybody is going to be successful on the regimen. Okay? Not everyone is going to have the disorder stop. For some reason, some people just continue to move on. The good news was that about 70 to 75% in that study, we had great success. What we've seen since then, and by the way, success means that from 5 to 10 years, we had stability with no regression. As a matter of fact, these are very interesting because I don't want to mention names. Patient number 1, patient number 25, and patient number 100 all lost their diagnoses of Alzheimer's disease. I believe it was patient number 1 who lived to be about, we started the patients usually around age 70. I think she lived to be about 85, and she died of heart failure. She didn't die of Alzheimer's. Okay. So one of the things that we're seeing is that, and we had a very sad case, it just reminded me of it. Last year, we heard from a family, they came to see us, God bless you. They came to see us, and we were happy to see us. I said, how is everything going? How's so-and-so? And they said, you know what? I came to tell you that our son died. Okay. He's doing really well. He died of something else. I know it's kind of hard to hear. You got people 90 years old telling you their 70-year-old died. But died of other complications, not from Alzheimer's. So, now I forgot what I was saying. I apologize. But patient 100, in that situation, these folks lost their diagnoses, and they were told, you never had it.
Right.
You didn't have Alzheimer's, because it's 7 years out, you're doing okay. 1 in 25.
You're better now.
With two, oh yeah. These folks actually regained the memories.
Mm-hmm.
These are the ones who are now remembering their grandchildren. They're living life great. They are having a fabulous time living la vida loca in their 70s and 80s. But the fact is, they truly did have cognitive impairment initially. But now when they go back and see, it must have been something else. Couldn't have been. Kind of like Columbo, if you remember Columbo. Yeah, just one more thing, though. You say you had Alzheimer's, but you're much better. Your memory's back, and I'm just not really sure you did. Can I talk to your doctors?
Alzheimer's isn't curable.
Exactly. Exactly.
So
You know what's interesting about things that are incurable?
Yeah.
What am I going to say? They're only incurable until someone cures them. Then they're curable. Like anything else. Yes, ma'am.
So, in your study, were any of them taking Alzheimer's medicine?
Yes, some were. But remember, these medications don't stop the decline of the disorder. They only help functioning for a brief period of time before the demise hits. So certain individuals were, not everyone was. And certainly that's where the double-blind placebo studies would come in that we don't have. But in a lot of the patients that we're seeing since then, what we're seeing is that many individuals are coming to us who are not on any of those therapies, not on any of those drugs, and they're doing very well. We've had some that, of course, have declined. But what's interesting is that what we're seeing is actually beating the statistics of the study. We're seeing more around 80 to 85% that are actually doing well. And by well, I mean they're stable. Back to the point I was kind of working with this young lady on, when we look at stability, we're seeing individuals who 5 to 10 years out had no memory decline, had no cognitive decline. They were stable. Okay. So we thought that was a great success. We were so happy with that initial study. We're like, well, we're going to start to treat people. Because in the worst case scenario, you take a complex of stuff that's not going to hurt you, all the antioxidants and a few other things, it's proprietary, I can't tell you what's in it. But if it can't harm you like that, what's the harm in trying? You know, somebody told you had a 75% chance of winning the lottery, would you buy that ticket? Mm-hmm. Yes, you would.
Okay. And what year was the study done?
Back in the 2004, 2005, 2006 area.
Can I ask a follow-up question?
Yes.
Linda and I were talking on our way in. Why don't more people know about this?
We're just getting started.
I asked why more people don't know about this.
We're just getting started in terms of spreading the word. Now, what's known, if you actually, for something very interesting, if you go to a lot of the websites in Australia, okay, talk to a lot of the doctors there, they know about it. And they know because we taught them. Now in Ireland, some of the nutritional people out there are becoming aware because we've been spreading the word. The Walsh Research Institute for the past 10 years has been working with doctors in Australia. Now there are over 100 doctors trained in this methodology of biochemical imbalances and evaluating them. Many of them are psychiatrists. Okay. In the US, we are a stubborn breed. We are usually the last to accept anything, and only when we go to world conferences where everybody's talking about it are we going to ever come to the conclusion that maybe we should try it. Did you ever hear the story about lithium? I know I've told the story a billion times, so I got to tell this one. You've never heard how lithium came to being, lithium carbonate? How? Somebody noticed in this small town in Texas that there are just sort of no depression there. People are bopping along, doing okay in life, you know, no depression. So it actually caused a group of scientists to swarm on this town. They took samples of the air, water, and soil. What they found was that there was a high concentration of lithium present. So they took that to the American Psychiatric Association and said, listen, we think there's a correlation. Nah, there can't be. It just doesn't make any sense to us. So they poo-pooed it. Well, that information got out to the rest of the world, the Scandinavian countries, the European countries. So they started working with it. Then all of a sudden, the World Congress came together of psychiatrists. And they were talking about how lithium was working great with all their patients. And so the doctors from the United States who were there said, this is fabulous. Where'd you guys get this? All this data, where did this start? They said, Texas. And they just went, oh. So now we have lithium carbonate as a use for people with depression and psychosis and so forth. In the same vein, what I'm really sharing with you is a story of how recalcitrant we are as a group of scientific practitioners, so to speak, about new therapies and new modalities. It takes us a long time to buy into that. We have to have our 20 or 30 years of research, if it's good research, not the one that's for 4 or 6 weeks and then take the drug thing, what we're talking about these days. Then we've got to put it through the accredited agencies. They've got to approve it, and then it has to get into the medical schools before stuff happens here. Now that's not a bad modality, but it's very slow. And most of the paradigms and the changes occur at research institutions, and it takes a long time to get to the clinics. Our original institution was one that involved researchers working with clinicians. So we were able to really assess different protocols and paradigms and put them into action if they made sense and were supported by research in a fraction of the time. And that's really how all this began. But most institutions don't have that. They're saying, but wait a minute, there's Rush and there's all these places and all these great institutions out there that have research. Yeah, but the research wing publishes its research in research journals. They're not talking to their MDs about implementing their therapies. Some of the MDs are kind of pretty good, and they're saying, you know, I'm kind of watching these guys over here because they're doing something with something that involves a patient that I've got, whether it's hematology or oncology, whatever have you, and I might be interested in working with that. But that's not the model or the paradigm we typically see with many of our institutions. We've got clinicians here, we've got researchers here, and most of the time the two are not talking. So disseminating that information tends to be very hard. Nowadays, we're doing consultations with physicians. We're starting physician training in the United States. We've been doing that in different parts of the world already. And what was really funny one day, I don't know whether to be insulted or proud, I was talking to a lady who was asking us a question from the East Coast. I think she was from Connecticut. And she said, I was talking to her and I said, well, ma'am, you know, I think you should probably have your histamine tested, and I think I'd like to tell you about that. She said, I know all about histamine. I said, excuse me? I said, really? She said, yeah. I said, well, you might also have a copper disk metabolism. And she said, yeah, I know about copper. I said, who are you getting this information from? Because they are pretty slick. He said, oh, this doctor in Australia. I said, what? What's this doctor's name? And she told me, and I said, oh my gosh, one of the doctors we trained. But then I got very concerned. I said, wait a minute. Why is it we're here in the United States and she's getting information all the way from Australia? And these are the folks that we help to train. I said, you know, we got a problem with communication here in this country. We got to fix that. I was happy and proud that our Australian doctors are doing great things, thanks to the Walsh Research Institute and the work that we've done in helping to contribute to their education. But at the same time, it means that we're really deficient here in this country in terms of spreading the word. When somebody who's looking for help has to go, 2,000-3,000 miles on the internet in order to get that. Boomerang effect, indeed. So that's why we've got a lot of obstacles, not to mention the pharmaceutical industry. Many things they don't want to be simply made known. The rumors about cures for cancer that are hiding, that they don't want to come out because of all the drugs that they're doing. I mean, that kind of stuff is just whatever. I have no idea about that stuff. But, what we do know is that there are good therapies that don't involve drug use at all. Reading an article in Men's Health, I think I told Dana about this earlier, and it wasn't Men's Health, it was Men's Journal. Tech toys. Okay, we're techies, right? Maybe not. Anyway, this one health journal said that if you were to take zinc, it was the cold myth, fact versus fiction. Vitamin C, they said fiction. Zinc, everybody knows about zinc. I said, do they really? So I started reading more about it. They said, well, day one of a cold, if you take 75 milligrams of zinc, you'll do better with the cold. I went, really? I said, do you know how many doctors would say you're poisoning yourself if you were to take 75 milligrams of zinc? I started laughing because this journal was talking about dosages that we use in our treatment protocols for people with all sorts of biochemical imbalances that are related to things like anxiety, depression, bipolar, schizophrenia, et cetera, et cetera, et cetera. So now I went, aha! In the layman's journal, not the Journal of Psychiatry, not the Journal of this from Scandinavia, not Switzerland, it's Men's Tech Journal. 100 best things a guy can do to have fun. In the dietary section, it says 75 milligrams of zinc is A-OK. There you go, doctor. Okay. Don't come to me talking about toxicity. Okay. We're slowly getting there. Our specialists are understanding. They're now using things like quercetin for vision. They're now using things like vitamin D in very high dosages, 50,000 international units. They're using things like zinc. One ophthalmologist wrote an article, and there was another cardiologist who wrote an article about supplements you could take. I said, doggone, these dosages and everything that's in there, it looks like one of our mini programs. Looks like they sat there and wrote out, you do this for this and this and this and this. There are 6 or 7 things that most doctors around the world would say were toxic in concentration. And this is being written by a specialist, a cardiologist from the United States of America. I was so proud. Very, very proud. Slowly, we're getting it. But we still have a long way to go.
What does the treatment look like for a person, if someone wanted to be a patient here for Alzheimer's? What is involved? What is the process? How many appointments, et cetera,
Good question.
Things like that.
Our Alzheimer's protocol is actually different
Okay.
than how we would treat truly 95% of the other disorders that we evaluate and treat.
Okay.
With Alzheimer's, the first thing is really the diagnosis. Okay. Different than Lewy body dementia, different from multi-infarct dementia, the Alzheimer's and Alzheimer's-like syndromes first have to be diagnosed, and those diagnoses usually come to us. We don't make those diagnoses. We don't make any diagnoses, as a matter of fact. People are usually coming to us with these disorders. Now, one test is truly key. I'm going to share with you treating the disorder. Then what we come to understand is treating the whole person relative to this particular condition.
Okay.
Because what we typically do is we treat the entire person. If there are gut issues, we help those gut issues. If there are brain issues, we do that. We do it all together. When we came out with the Alzheimer's paradigm to keep this an appropriate test, an appropriate study, we only treated the Alzheimer's aspect. So quite honestly, we didn't look at methylation disorders. Someone is sitting back thinking, oh, Dr. Mensah didn't think about methylation? You know, my daughter once said to me, do you just see the whole world in terms of methylation? And I said, no, she's her PhD getting, at the University of Maryland, in sociology. And I looked at her and said, yes, everything's about methyl to me. And in fact, I said, I walk downtown Chicago, I walk in the airport, it's going, oh, they're methylated. Methylated. Whew, that's a pyrrole. Watch out for that one. Oh, Irish descent. I'm sure pyrrole is running rampant. Oh, very zinc deficient. Oh, honey, your nails are littered with white spots. She's got pyrrole disorder, low zinc deficiency, probably copper toxic, probably has very bad PMS. Goes on and on and on, sitting there. My partner, Dr. Bowman, and I at the airport, we crack ourselves up because all these little stories are created about people who are just watching, minding their own business. They have no idea we're probably just not as stable as we think we should be if we're making all these stories up. But that's because our world is about chemistry, and people are so statistically present in their chemistry and visible that you can see the same story over and over again. But we had to stop that when it came to Alzheimer's. With Alzheimer's, all we needed to know is what the level of zinc was in the system, as opposed to all the testing that we do. It was just zinc. Why? Because the elements that we worked with were designed to stimulate one of those proteins in the brain. Remember I told you about zinc being used by these brain proteins? That's it. If you don't have enough zinc on board, this person may actually get worse cognitively. They may become more depressed. They may become more anxious, more agitated. So we have to make sure the zinc levels are appropriate. If they are not, we will actually front load them with zinc, retest in a month or two as quickly as we can to make sure zinc levels are appropriate, and then we can start the therapy. But the idea is first, in terms of becoming a patient, you simply say, hello, I'd like to be a patient. Okay. And then we talk about the general process of becoming a clinical patient.
Yeah.
The next thing involves usually what is a 45-minute to 1 hour discussion with a nurse.
We're talking about specifically Alzheimer's here, right? Or
yes.
That's okay.
Well, there's general, but it also applies to Alzheimer's. So
okay.
This, you asked about the Alzheimer's, and I'll share with you what we go through.
Right.
Usually the family members come in with the patient, of course.
Yes.
And then they meet with a nurse for about an hour or so. And then they'll meet with us for a physical examination, us being the doctors. And then some cursory review of systems type stuff, general stuff that you'd see most doctors do. And then we sit down and we have another conversation, part 3, for probably a good hour to an hour and a half, depending on the time variation. So really the day kind of looks like a 2 to 3 hour day for the average patient visit. Okay. Same for Alzheimer's. Okay. Then the question becomes history. In the process that we are going through as doctors and the patient, we look at family history, we look at the patient's personal history, trauma history, dietary evaluation, all those things we talked about and I hinted about, all that goes into every case, every presentation, every discussion. After all that is said and done, the one test that we used to order was just that zinc. Okay. Because Dr. Mensah did not care about anything else except getting that patient started. But now here's the interesting thing. We said, well, we're not treating the whole person then, are we? Because what if there are other variables that could be affecting inflammation in the brain? So we started talking to patients as sort of a tester to say, if you had to pay the same amount of money Would you want just the Alzheimer's dealt with, or would you want some of the other conditions in your system dealt with? And 99% of the time, in fact, I don't remember anyone saying just deal with the Alzheimer's. So we dealt with everything. Now, when we do that, our full battery of testing comes into play. But our key focus is still on the Alzheimer's. Okay? If stuff starts to go every which way but loose, for whatever reason, I push everything else back and I say, we have to make sure you do this. And I'm talking about compliance. Because we'll say, well, you want to take some of this, you want to take this, and this dosage of this, and this, and this. And somebody will say, you know what, he can only get down 3 capsules a day. I say, fine, here you go. That's it. Okay. So the process is still the same, whether it's schizophrenia or bipolar disorder or Alzheimer's. Right now, the testing and the big pool is the same. Emphasis is different.
Okay.
It is this plus that. For most cases, except autism, it's only this.
Okay.
They don't get those particular therapies that are dealing with the oxidative stress and the inflammation quite so heavily. Okay. And then after that, there's a 6-month follow-up, which if you're coming in from out of state or out of country, we're now able to do by telephone.
Okay.
Usually, doctors want to see patients in person, but it's becoming kind of hard. So we're now having the capacity to deal with the same process, the nurse and both doctors by telephone, and then retesting the chemistry 6 months later.
Okay.
The discussion with the telephone phenomenon involves symptoms. How are you doing? Da 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 da. But you see, it's the chemistry and the lab tests that are actually telling us for sure if the symptoms are correlating with the chemistry, and so we know we're on the right track. Anybody can say, oh yeah, I'm feeling great. You've had some teenagers tell some whoppers, I'm feeling great. Mother notices the dog's coat of hair is looking real shiny. The plants are growing real nice and tall. They did everything but take their supplements. They gave them away. So there's a way I always tell teenagers, we know if you're going to cheat, because your tests will show you're going in the wrong direction. So after 6 months, then we go to the year mark. 1 year after you've started, we revisit, we retest again. So in the first year, there are 3 checkpoints. After that, most people tend to be on cruise control, and we check once a year. Some of our Alzheimer's patients, and actually a few of our Parkinson's patients are coming in at 2-year intervals now. And sometimes, quite honest, I've forgotten they were there. Sounds bad, doesn't it? But on the other hand, they're coming in and say, I go, how are you? I said, Dr. Mensah, how are you doing? I'm just fine. We're on vacation from Texas. And so how's he doing? Oh, he's just doing so well. We haven't seen you in a while, and his memory hasn't changed. Everything's just going fine. I said, okay, well, good. So what can we do for you? Well, we're just here for our retesting. Just looking for a little booster. And so we do that thing we do, and they go on. I love those. And we've got all kinds of family members who come in because people talk and things like that. They say, oh, by the way, so-and-so, they're doing really well. I want some of what they're getting. So you don't need it. You're not getting it. Okay? It's not for you. But so we made available to us these visitations by telephone, so to speak, so that now everyone doesn't have to be present and spending lots of money coming to Chicago, because we do have patients that are coming literally from all over the world. Once a year, on average, is the follow-up schedule. But some of those folks, like I said, it's oftentimes once every 2 years. The ones who are doing really well.
When you work with an Alzheimer's patient, how often does this regimen that you prescribe work right away? Or is there some, we need to...
I feel another story coming along.
How often do you have to play with the levels and the dosage and the...
Not often.
Okay.
Unlike many of the other patients, dosing must remain the same for a certain period of time, because some individuals do have idiosyncratic reactions where they may get a little bit more stimulated, where things may happen. We may have to say, okay, I want you to decrease the frequency for the week. But we start really at once every 3rd day. That's all they have to do in terms of the regimen. And then as they're tolerant of that, we gradually build up. Now there is a version 1 and a version 2. The version 2 is more intense. when you graduated through the different stages of version 1, then you move to version 2, which is more concentrated, and then you move to a greater frequency of version 2, and you basically stayed there ongoing. In fact, I would dare say about 70% of all of our patients rarely ever get to version 2. They're holding steady on version 1. Okay. So the need for variability and change is usually fairly minimal. The reason I kind of chuckled when you first started was because when we were working in this really small town out in Illinois, they didn't have a lot of money, and the labs didn't have a lot of testing capacity. So we sat there feeling like, neurosurgeons in the jungle. How do you work without tools? So these folks who had Alzheimer's who came to us, I said, gosh, we can't do testing. What am I going to do? You know what? Here, I want you to take zinc, and I want you to take vitamin B6, and I want you to take these specific dosages. I said, now, I've been to the stores in your area. I know they carry this. So they'd say, well, go ahead and try it. They come back and, Dr. Mensah, we can't find it. So we were talking to people in the town, found one store that could get it for us. They never even met us to this day. Okay, the whole town was busy buying zinc and B6. Why? Because what happened was when they started taking zinc and B6, the individuals who had Alzheimer's, who were sitting down, sedentary, sitting there, doing nothing, they developed personalities. They started talking again. They wanted to go to clubs. They wanted to go golfing. They wanted to do all sorts of things because their family members were telling us. That's how we knew. We got phone calls from people we'd never met. What did you do to Gertrude? Sorry, ma'am, but what do you mean by that? Well, she's talking too much now, and she wants to know what's happening. She's talking about the news and Obama and this and this and this and blah, 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 blah. I said, is that a bad thing? She said, no, but what'd you do to her? I want some of that. I said, ma'am, we just gave her zinc and B6. That wasn't even the treatment protocol yet. That was the introductory piece. So when you ask, how long does it take? For many people who are depressed or are showing the depressive signs of Alzheimer's disease, they really may be deficient in nutrients, okay, because many of them don't eat. So without eating, you can't get your foodstuffs broken down, you can't make neurotransmitters. And so when we gave them a front load of zinc and B6, all of a sudden personalities started coming out. And when they did, we knew really we're at a good level to start the therapy, the real treatment. And by the way, I'm going to tell you this, one thing I should have talked about earlier. Many doctors are now saying, yeah, we know about B6 and that's an important part of the treatment of Alzheimer's. No, it's not. Do not be deceived. Vitamin B6 is not part of the treatment protocol for Alzheimer's. Somebody who doesn't have Alzheimer's but has depression will do better based upon just using vitamin B6 and zinc. And that's a whole other story. But the fact is, because people have been front-loading with vitamin B6, might I say long after we started doing it, okay, they're doing better cognitively because they seem more aware, more alert. And that people are mistaking for having started the treatment for Alzheimer's. It's not the treatment for Alzheimer's, it's the treatment for some of the cognitive aspects that are seen probably secondary to malnutrition. Okay? But if you give those people the right stuff, you can see effects as soon as just a few days to a week. They may just perk up. And usually by about 2 or 3 weeks, they're very different than what you were seeing before, on average. Okay?
I don't have a question, but I do have a comment. I have a grandnephew who has been on protocol here for some years. And
Okay.
he went from Asperger's, defined as Asperger's, whether it was or not, I can't say, to now he is a senior at a Catholic school in Campbell, Pennsylvania, with a very, very structured school regimen. He's fullback on the football team. He's probably not going to get a scholarship, but he's looking at medical school. And for when I saw Joseph as a child and tried for years to get my niece to come here, I think they came the first time when he was about 8. So however many years ago that was.
Wow.
So it's a really wonderful success story.
Thank you. Now, the check's coming in the mail. But, no, we've never actually met.
Actually, I return it.
You're so sweet. Thank you. I'm glad to hear that he's doing so well.
He's doing extremely well.
those are the stories that just make our days.
But his mother's the angel in this story.
She's the one who pushed hard to get him there. Wonderful. Thank you. I'm really glad to hear that. It's that's what we do and why we do it. You know, it's humbling, very humbling. I'm just glad to hear it. I'm glad to hear it. Any other questions or comments or random musings or otherwise observations? Thank you for coming on this cold Chicago night, and feel free. Questions are free. You just call our office if there's anything you want to ask or talk about. We're more than happy to talk to you.